Hello, everyone. My name is Mike. I'm a physical therapist and your host of the Health Me podcast. Thanks for tuning in, and remember to leave a like and subscribe so you don't miss any updates. This week's podcast episode, we discuss all things ACL and go over all the work that needs to be done surrounding this very common and costly injury. Naturally, we will discuss the rehab process of how clinicians have treated this knee injury in the past and where it is today. As our conversation today continues, we will also cover how technology has allowed us to improve outcomes in rehab, how to compare your injured and non-injured leg, and where fatigue comes into play when testing athletes or patients in return to sport protocols. A major part of ACL rehab is expectations and preparedness. Today's episode, we will discuss how to test for these very important factors and highlight the importance as it is found in the research. Here to discuss this and more is a researcher, clinician, and thought leader in the space of ACL rehab. To date, he is responsible for the creation of the Athletic Movement Index certification, the Run Safe program, and the ACL Play It Safe programs that are nationally recognized to help reduce injuries in athletes. Most notable, he is the developer of ViPerforamnce's Athletic Movement Index, which uses wearable sensor technology to assess athletes' risk of injury during a specific series of tests and movements. Outside of his creations and accolades, our guest has started a company focusing on helping public safety workers get the adequate rehab they need to perform well, and is a mentor for many in the physical therapy space. Without further introductions needed, here's my conversation with Trent Nessler. You're passionate about many areas within physical therapy, including work with first responders as well as combat athletes. But today we're going to be talking about where things kind of got started for you.
Sure.
And when did you start to think about ACL injuries and how important reliable and objective data is to our profession?
Sadly, I started thinking back in the 90s. So I graduated in 97, started treating ACLs pretty much out the door. This is really before Hewitt, Powers, Stearns, Myers, and all of them had published all of the literature that's out there today around ACLs. And I was rehabbing these kids, because most of them were high school athletes. I was rehabbing these kids, and I was watching them on their discharge, evaluating their gait. And I was seeing certain movement patterns that I knew intuitively put them at risk for a re-injury. And this is before we had all the research about re-injury rates and all that. So, to me, it discouraged me because as a PT, I'm like, I'm not doing well enough. And so I really started to dive into it. I came from a personal training background. I've always been a weightlifter. And so I knew that if I could evaluate it better, I could strengthen it better, I could get better programming and help to improve that. So, this all really started back in like 98, 99. Started with video cameras with the beta tapes in them, the big cameras, and filming people in the clinic. It's progressed from there. So it's been a long, long journey, and it's exciting to see, I've been in the profession for over 25 years to see it come to fruition now and what we're able to do now.
I believe it. And seeing that transition to where it is now has to be very interesting. And I was wondering what kind of objective data, or at least how has objective data changed over that time period? Because you have, I'm assuming, seen and worked with a lot of different devices and things to try and make a step towards that direction.
Yeah, historically, we solely depended on our eyeball to do it, and quite honestly, a lot of the stuff that we still do is very antiquated. We still in many cases rely on that, technologies have come along. One of the first technologies I started using that was really allowing me to be a little bit more objective was a technology called Dartfish. It's a slow motion technology. It's used a lot in the Olympics and in sports. Really allows you to slow down movement, really analyze movement much better visually. The hard part of that is quantifying movement. How do you quantify 10 degrees of valgus versus 20 degrees of valgus on a 2D video? And so we began to recognize that, and people were trying to do it. People were trying to provide quantitative data off of 2D video. When we looked at it and we went to the lab and compared what we did on video to the lab, it wasn't accurate enough. And so that kind of transitioned us forward to the technologies that we're using today, which is more of a wearable sensor technology, which is quite honestly probably one of the most accurate ways to do it. And so, seeing those transitions from eyeball to video technology to wearable sensor technology, and still the majority of our profession still relies upon eyeball. And I think with technology and where it is today, it really should be moving us forward towards that, because it used to be that technology was so cost prohibitive that, what clinic can spend 20 grand to, really do 3D motion capture, right? But it's not like that today. It's very affordable. It's a billable service. And so what we've tried to do is we've tried to make it very, very objective, and at the same time affordable, and at the same time a billable service that you can use in a clinic. And then also at the same time, the way that we develop this is we collect right now, the current version, we collect 1,500 data points for every assessment we do. The new version will be 3,500 data points for every assessment that we do. So going back to 1,500 data points, we've collected data on over 37,000 athletes, which equates to 43 million data points related to human movement. That's completely objective, no eyeball stuff. So when it comes to data warehousing, mass data collection, this is the largest database for human movement, because there's some others that are out there, but they all go by eyeball. You eyeball it, you put it into a computer, and then they're capturing it in that fashion. This is the only one that's capturing it all through motion capture. And it's such a large quality, or such a large quantity. For a lab to do that, it would literally take a lab 20 years to collect that kind of data. And that's part of the reason, I'm a data geek by nature. I love data. I love research. I love looking at research. I go through the literature at least twice a month, looking for journal articles and seeing how that's going to impact me. But one of the things that was important to me is that the data that we're collecting be useful for the profession, and in a significantly meaningful way. Like, it's so amazing, like I'll give you an example. One of the things that's out there that we know from McPherson's published a really good paper in 2020 that looked at concussion rates and ACL injuries. And what they found is that you are 3 times more likely to suffer an ACL injury up to 3 years after a concussion. So that leads to the question of, well, why is that, right? And so one of the things that we track with our system is we track concussion history. And one of the things that we see is that if an athlete has a history of concussion, their frontal plane control in single limb performance is much less. So they have a greater magnitude of valgus when they do single leg squats and hops and in multi-directional hops. And the speed at which that valgus occurs is at a much higher speed. So then what that does is then that drives clinical practice patterns. Because it used to be for concussion, we would do a lot of vestibular stuff. We do some neck stuff. We do some balance stuff. We never did single limb training, single leg squats, single leg hops, multi-directional hops. Now this gives us the evidence to say, hey, you know what? We should probably be including this in here to address this piece of the concussion that we haven't even known about yet. So that's where I get super excited, because capturing mass data like that is truly going to be the new trend. I don't know if you saw the paper by Hewitt. He did a clinical commentary in the International Journal of Sports Physical Therapy last month on how mass data is going to drive more clinical practice patterns than research itself. Because of the mass way that we're collecting data today versus 10 years ago, we will see those trends come to fruition before research even is able to vet that out.
Yeah, and it's almost like you're seeing it in real time, and other clinicians are going to be getting it. Where the only thing I do
am concerned about is just getting bias data where perhaps you may be seeing a particular patient population where it's only combat athletes, and these people are going to be coming in at a higher level than other areas. Is there a way to perhaps account for biases? I mean, I want to get into the technology a little bit later and kind of cover where you're specialized, but I think the bias part might be important too to cover.
Sure. So, and that's true. And what puts a high school soccer player, female soccer player, at risk is different than a male running back, same age, for football, versus a NBA player versus a NFL player, right? There's different spectrums, right? And traditionally, and I won't say what movement assessments, but there are some certain movement assessments that said if you score this number, you're at risk, no matter what sport you play, no matter what your gender is, no matter what level you're playing at, et cetera, et cetera. And so one of the things, we identified that early on. And so one of the things that we do is we capture your age, we capture your sport, we capture what level of sport, and we also capture your position in that sport. So the idea is that once we have enough data, we can pull out 16-year-old female soccer player playing this position, and then compare that to norms of that same position, also all of the demographic information is similar. So you're comparing that person to normative data for that person at that age, at that position, at that sport. So, right now it's not there. But, again, that's where mass data comes into play, where you can start to do that stuff. And that's what we're doing. It's funny because that's what we're doing with our first responders is, so in the first responder space, we look at somebody moves very differently in their first 5 years versus 5 to 10 years versus 10 to 15 years versus 15 to 20 years. Because as you get older in the fire services, especially, typically you're being promoted, you're moving to different positions, you're not as active. And so what puts, a lieutenant at risk versus a straight firefighter is going to be very different, right?
Yeah.
And so again, trying to break all of that out to try to reduce those biases, and make it specific to the person, the gender, the sport, the age group, et cetera, and previous history.
Yeah, and this is all amazing, and we're going to get into technology later. But I think for people who are just listening in on like, what are we measuring? Who are these people that we're talking about? Yeah. Typically, what we're usually kind of referencing are people with ACL injuries, because this is where you kind of develop the technology, correct? On patients with ACL injuries. Yeah. So maybe just highlight like what exactly is an ACL? Maybe there's a patient of mine or somebody that's listening they have no idea what the heck an ACL is. Sure. Maybe what are some of the most common ways that you found that ACLs are injured?
Yeah, so anterior cruciate ligament is the ligament that we're talking about. Of the knee ligaments, it is the one that is most commonly injured. It is the most costly. It is also the one that results in the biggest delay. And if you got your femur here and your tibia here, it is the one that prevents your tibia from moving forward on the femur. And so it's really important, especially if you're planting and cutting a direction. Most ACL injuries, there's about 250,000 every single year. Most ACL injuries, over 80%, are non-contact in orientation. What does that mean? Nobody actually hits your knee. Typically, it's a coming down on the ground, you stop and you cut directions where the knee kind of buckles in. Everybody's seen videos of that in some form or fashion, and they tear their ACL. The problem with the ACL is it's also a ligament that has to be replaced. There's some literature out there about copers and non-copers. Most of that literature is coming out of Australia, which is a socialized medicine kind of environment. That being said, what I've seen is that people who go without an ACL, who are still in cutting sports, end up having major problems down the road because there is not that resistance to that anterior tibial translation, which this motion of the tibia on the femur tears cartilage. It tears your meniscus. It wears away the cartilage on the underside of the femur, and that can result in big problems down the road. So any athlete that I ever see that's got an ACL rupture, I'm typically telling them that they need to get that replaced. Replacement, there's a lot of different procedures that are out there. There's some really good advancements in ACL reconstruction. the typical rehab has really not quite I won't say the typical rehab, the typical course of treatment to return to sport has not really changed. Most studies say that it should be no less than 9 months. Now, there are accelerated programs out there, and I travel all over the country, and I've seen some of these accelerated programs. And unfortunately, what I think that happens is it becomes more of a competitive edge to get patients than really what's in the patient's best interest, unfortunately. Because people hear, oh, I can go back to sport in 6 months. If I go here, I'm going to go there. What they don't realize is that they're setting them up for a greater injury. Dr. James Andrews says that anything under 9 months, you add 5% increased risk. So you're at 28% increased risk of re-injury at 9 months. Add 5% at 8 months, add 5% more at 7 months, add 5% more at 6 months. So you can see your re-injury risk goes up greatly the sooner you try to go back. Timothy Hewitt published a paper that said people shouldn't go back for 2 years. I don't know any athletes that's going to do that.
Yeah, no, right.
But 9 to 12 months is pretty common. With the advancements that we've had in rehab, with the BFR is amazing. It is a game changer for me. I recently had a multi-ligamentous knee injury, a displaced fracture in my hand, neuropraxia in my arm. Started BFR day 2 post-op, and I was back on the mats at 4 months. That's typically a 1-year process.
Right.
BFR is absolutely amazing. If you look at the research on it, if you look at the data on it, I actually teach a BFR certification course. And the more I've gotten into it over the last 4 years, it is an absolute thing that needs to be done as a part of ACL rehab. I mean, it's just with the growth hormone that's released, the IGF-1 that's released, which are all hormones which help healing, help bone healing. There's studies now looking at early BFR and the bony plug take and how it's accelerating the healing at the bony plug and the quad development. So there's just so many positive benefits of it. An ACL today is much better than an ACL that was done, when I first started practice, definitely, and even better than what it was even 5 years ago. So I think the things that we're doing today, there's so much more to it, with recovery equipment that we have out there, Normatec, HyperIce stuff, with the BFR that we have out there, with class 4 lasers out there. I mean, all of this stuff, which just so accelerates the process, but still return to play 9 months.
And what exactly?
That's a long-winded answer.
Yeah. No, it's okay. It's you did a great overview of where the profession has at least gone now. And this idea of blood flow restriction training is great. And maybe just highlight exactly what that is. Some people may not understand.
Yeah.
The idea, I believe, to my understanding, you're able to train at lower intensities with higher volume, and it's allows you to load the tissue in a more adaptable way. So that way you can start training at lower volumes and load the quad muscle or whatever muscle you're trying to work out in particular, but I'm sure you can say.
So in very simplistic terms, you put a device, a cuff or something along those lines. There's 4 spots you put it: up in the armpit, down on the femoral artery and the legs. You tighten that up to a certain millimeters of mercury, and then you start to exercise. And what it does, because arteries have muscle to them, veins do not, it compresses the vein, but not the artery. So blood goes into the muscle, but it does not leave the muscle. So what ends up happening is that as you're exercising, blood's going into the muscle. And what happens is the muscle reaches its full capacity where it can't take any more blood. So as you're exercising and you've got the max capacity of that blood in there, the exercise and the muscle activity is pulling oxygen off of that blood. Well, eventually you pull all of the oxygen off that blood. There's no more blood coming in there. So the muscle starts to fatigue. So you get 2 effects from BFR. Number 1 is a localized effect. Because you've pulled off all of that oxygen, what ends up happening, because the muscle is still exercising, it's becoming fatigued, you end up increasing motor unit recruitment, which for ACLs, for quadricep development, is absolutely essential. It's one of the things that we fight early on in the early phases of rehab, is getting that full quad to fire.
Mm-hmm.
So this is a really good way to get that full quad to fire, keeping in mind that when you're using BFR, you're typically exercising it at about 30% of 1 RM. When I say 1 RM, that's 1 rep max. So your maximal amount of force that you can do, typically you're doing 30 to 40% of whatever your 1 RM is. So in this instance, I do a lot of BFR with quad sets. I'll do BFR with neuromuscular stem and quad sets. I'll do it with body weight squats, straight leg raises, and you get that quad recruiting. You can literally get it recruiting within 2 or 3 days post-op, which, anyone that's done ACL rehab, that's something you're constantly battling.
It's essential, yeah.
Yeah, all the way through the process. So that's the localized effect. So there's also a systemic effect that occurs. And what happens is, as you continue to exercise, what you're doing is you build up lactic acid and you stimulate a cascade of chemical reactions that take place. One of those chemical reactions is that there's the release of growth hormone. Growth hormone is a hormone that causes muscles to grow. It's a hormone that also causes soft tissue to heal faster. So the levels of, or the concentration of growth hormone release is similar to as if you were exercising at 85% of 1 RM.
Mm-hmm.
So the growth hormone release that is released with a very low level of training is similar to maximal training, which is awesome because you get that effect without putting stress on the joint. So I can get that effect in somebody who's 2 days post-op, whereas typically I wouldn't be doing that for 9 months down the road.
Right.
So that's one thing. The other thing is another hormone that's released is called IGF-1. The IGF-1 helps with both bone healing, but also with the muscle growth. So the bone healing piece of it, and that's what I was talking about with the bony plugs, some studies are starting to look at the impact that it's having on the bony plugs for ACL reconstructions. One thing I can tell you is I had a displaced fracture in my hand, split the hamate right down the center, dislocated. I had to reduce it myself.
What'd you do?
And it was training mixed martial arts.
Oh, okay, got it.
Yeah, so they split right down the center, and the hand surgeon was going to pin it. So I had 3 weeks before surgery, I had them lay some extra casting along the palm of my hand so I could work out. And then I did BFR on my arms while working out. And the healing that occurred in that 3-week period of time was significant enough, one, that the fracture was stable, because when he went and tested it, he thought for sure, he's like, we're going to have to pin this because it's unstable. It's broke right in half. And when he took the cast off at surgery, went to test, he's like, holy cow, it's stable. And then he did an x-ray and he's like, man, it's healing really good. He's like, I'm going to leave it. So I got out of it without being pinned, which is great.
Nice.
But it goes to the point of the impact that IGF-1 can have at a high level. I will tell you, I had a mixed martial artist ruptured his bicep, and typically that's a 6-month process. He had some medical complications. We started BFR literally about 3 days post-operatively. He was back on the mats getting arm barred at 3.5 months. That being said, his growth hormone release was so high that his primary care physician called him because his testosterone levels were so high. And she was calling him because she was asking him if he was taking a testosterone supplement. The only thing that we could relate that to was the use of the BFR, because he was using it a lot. And he's using it as part of not only his rehab, but we also use it for part of our performance training. So there's actually a benefit you can use with BFR in cardiovascular conditioning. Right. So, for my grapplers, because our typical rounds for a lower belt are 5 minutes, for an upper belt, they're 10 minutes. And so improving your gas tank is really important. Maintaining your gas tank during injury is really important. And so there's a whole protocol that you can do using BFR to increase your VO2 max, even when you're not training at high intensities.
That's remarkable. And even for the simple fact that those bony plugs is really interesting, because even for ACL, what happens is they reattach your ACL or whatever graft to your bone. And so making sure that you can get those markers and get that healing faster and training at like what a perceived higher volume or perceived higher 1 rep max is extremely important. And we also talked about re-tear rates, which I kind of want to go back to.
Yeah.
Are you seeing perhaps like less re-tear rates as a result of getting into some of this objective data? And, in the realm of re-tearing rate, we want to make sure that it doesn't happen at all. And we kind of look to maybe where are people not getting ACL injuries? Are there any sports in particular that maybe aren't receiving ACL injuries, and maybe we can learn from that?
Yeah. So a couple of things. Number one, re-injury rates around 28%. That's what the current research is saying. We do have a retrospective analysis going on where we've had in St. Louis, big hospital system there is SSM. They've been using our system for about 4 years now. They've been returning athletes to sport using our criteria. And they're doing a retrospective analysis to see what re-injury rates have been among those that have been returned using our criteria. Now, this is only preliminary data, but it looks to be about half of what industry standard is, but that is yet to be published, and we don't have all of that data yet. That being said, we're still too early in the game to really kind of know, because the system's only been out there since 2017. Even though we have 450 systems across the US, there's a set number of them that are using it as a part of return to sport and return to play using our criteria. That being said, one of the things that we include in that is what is called the TSK-11, it's the Tampa Scale for Kinesiophobia Form 11 form. And we've seen high correlations. Matter of fact, we have a multi-site study going on right now where we've seen high correlations that if people have high levels of kinesiophobia, you can see it reflected in their movements. And when we improve their movements, their kinesiophobia, as reported on the TSK-11, goes down. So those are all really positive signs, because we know that if you score 19 or greater on the TSK-11, you're 13 times more likely to re-injure with return to sport. So those two things in conjunction with one another are giving us some very positive indications that we're on the right path. The other question you had was around sports, and what sports are immune to ACLs. And I started thinking about that. I'm like, well, swimming. Swimming's that's one that probably you don't see a lot of ACLs. And hockey, because a couple of reasons. Number one, your feet don't do the normal movement patterns that you get with running. Hockey, you're kind of keeping your feet more in contact because you're skating, right? And also, if you look at how hockey players tend to skate and how they move, a lot of that is a lot of glute max and glute medius strengthening, which you and I both know that, especially with ACLs, one of the things that we target into is the glute medius and the glute max. And if you look at hockey players, they got really strong glute med and really strong glute max because of that skating type of motion. So, when it comes to sports, typically those are, two sports I can think of that are probably a little bit more immune to ACL injuries. All of that said, some of the highest sports, women's soccer, women's basketball, volleyball, lacrosse, football, a lot of your running and cutting sports have high ACL injuries. Mixed martial arts, they have a fair amount of ACL injuries, and most of those, believe it or not, are non-contact. It's not somebody kicking them in the knee. Typically, it happens when they go in for a takedown. So they shoot in for a single leg, and it's typically when they're driving up that knee falls into that frontal plane motion, and they end up tearing their ACL. So there are some sports, very limited amount of sports, where ACL injuries don't really occur. The question is has the injury rates really changed since 97? No, sadly. Despite the plethora of research that's been done since 1997 to today, injury rates still remain around the same. Re-injury rates still remain around the same. And quite honestly, I'm probably one of the harshest critics of my own profession. Part of it has to do with it. A lot of the stuff that we still do for ACL rehab is antiquated. The fact that I have ACL rehab therapists asking me about BFR and how they should use BFR tells me like, wow, we are behind the ball. Like that should just be a natural part of what you do as a part of your ACL rehab.
Right.
So I think that, and part of that is really keeping up on the literature. It goes back to our profession. We're taught to be a profession. We're taught to dig into the literature. And most of us, when we get out of school, we don't get back into the journals. One thing I do on my schedule every single month is I have two dates once a month to get into the research, because it is that important to be up on the research. And again, it's going to change the way you practice.
And not only just look in the research, but look at other providers. One thing that I've been able to do with this podcast, thankfully, is, talk to other providers to see what they're doing. But also, I go on social media and look at other providers who are like, hey, I'm having success with this, and you should be not listening to me, but like, I believe that this is going and improving. And, some of the reach rates haven't changed, but I think one thing that's interesting to know is that, we become a definitely more athletic population, and the fact that we haven't had an increase in reach rate, I think is at least something's at least balancing at the very least, So I think in that aspect, it's good for the time being, and we still have more to go, and there's more things that we need to continue working on. But for the time being, I think that we're heading in the right direction. I think there are professions and people such as yourself trying to push the boundaries, and we need to continue in our efforts to try to build that and make it better. But why do you think there's such a discrepancy? Like, is it that we're not prepared coming out of school? Is there just so much variability? I guess, like, where do you think this variability in treatment of ACL injuries starts and begins?
Quite honestly, it starts with a surgeon. And I have the fortune of traveling around the country. And, what I see from an ACL surgical standpoint and the protocols, because a lot of us, rely on the surgeons to give us a protocol, and the protocols I see going from New York to California to Las Vegas to Washington, they are all over the board. There is no consistency. I was, and I won't say where, but I was with a very high level mixed martial artist who had an ACL reconstruction in the area he was in, and he was still braced for 4 weeks. He had no meniscal injury. He was still braced for 4 weeks, and he did not start PT for 2 weeks. Where I came from, I spent a fair amount of time in Birmingham, Alabama with Dr. Andrews and Kevin Wilk, and we saw our ACLs the next day. Like, we were taking them out of their hospital beds, bringing them down to the clinic and starting rehab, so that's a huge discrepancy. That, and you and I both know, like 2 weeks, man, that's ridiculous. That's a massive amount of time for somebody to be off. The other thing is too, is that, as therapists is really pushing what we do, and really increasing our knowledge of what should ACL rehab look like. There's a really good study that was published by King, and one was published by King, one was published by Ithaburn. Both were in the American Journal of Sports Medicine, 2018. King was the first one that looked at ACL reconstructions at 9 months post-op when they're getting ready to return to sport. And what they found, despite the fact that they had rehab with a sports certified specialist, they had their rehab. Even at 9 months, their biomechanics still looked horrible, both in bilateral and single limb. Ithaburn went a step further at 2 years post-op. 2 years post-op, their bilateral had improved, but their single limb biomechanics was still horrible. They were still presenting with biomechanical movement patterns that put them at risk for re-injury. So it goes back to me in why I do what I do, is that I'm a firm believer that we were all taught to look at movement. We were all taught as a profession. When I came out of school in 97, we were labeled the movement profession. And I can't tell you, even back then, how many therapists actually looked at gait, let alone, how somebody moved. And the problem is that, movement, human movement, occurs at such a fast rate. For example, our sensors capture motion at 220 frames per second. The human eye is around 200 frames per second. So for you to be able to identify that somebody's falling into a valgus at 200 degrees per second, You can't do that. You can't quantify what that speed is. But one of the things that we found is that the speed of valgus is one of the most important things. If you were to stand up right now and stand on one leg and you put your knee towards 20 degrees of valgus, it probably wouldn't hurt you. But if you did that at 220 degrees per second to 20 degrees of valgus, you're probably going to tear something. And so what we found is that the speed factor is the most important thing. So one is, I think that we need to look at biomechanics better. We need to be looking at more single limb. I'm surprised at how many ACL rehabs I've seen that still don't push single limb performance, still don't start doing single leg squats. They do it way late in the game. They start doing single leg hops way late in the game. All of that stuff's not done typically until they're getting ready for sport. That's too late. You need to be starting on that stuff earlier on in the process, whether that's a single leg sled or something along those lines, but at least you're getting them to control that frontal plane motion. So I think as a profession, we need to seriously look at biomechanics better. We need to become better evaluators of biomechanics. And the only way to do that, I think, is really by integrating technology, because we may think we see this or we may think that we see that, but when you measure it with technology, there is no ifs, ands, or buts about it. It is what it is. And I will tell you, when I talk to our orthopedic surgeons, because there's a lot of orthopedic surgeons who use our system for making return to sport decisions. And what I tell our surgeons is this holds the therapist accountable to changing movement. Because at the end of the day, the sensor does not lie. Yeah. Your program either worked or it didn't work.
Right.
If it didn't work, you better figure it out. And what I will tell you is that we have the ability, and that's part of what we've been doing, is we have the ability to kind of whittle down to what exercises are the most effective at changing movement. Matter of fact, and I don't want to do a shameless plug here, but I just published a book last month called How to Build a Badass Firefighter. It's available on Amazon, and basically that's the whole book. I go through the science behind why we do what we do. I go through the science behind the movements that we should be looking at. I go through all of the different movements that we look at. How do you interpret the results of those movements? And then most importantly, what is a methodology to actually change those movements? And it's not just my thoughts. It's not just my theories. It's what we've seen from the system, that when we apply there's 1,000 different ways to do an exercise. But when you apply certain methodologies to that and the way that you prescribe those exercises, you'll have better results. So that's what the whole book is about, is really helping people understand, like, how do you really look at human movement and then interpret that and then truly change it.
Well, my question for you is that, we're going to, as an athlete, especially working, if you're on the field, you're going to have to be doing those valgus movements. Like, your body's just going to do what it's going to do.
Yep.
And is the idea to just get that limb in those motions and get it used to controlling at such high velocity? Or I guess, like, what is the methodology behind that? Because again, our knees are going to move however they move, especially when you're being chased by like a 300-pound guy, you're not going to be like, oh, I need to slow down here. So I guess, like, how do you train that?
Absolutely. And that goes back to, your knee is still going to move into valgus. But if you can control the speed at which it does that, that's where you prevent injuries. And so it's not about just stopping the motion. And if I can reduce the magnitude, that's great, because 20 degrees is more harmful than 10 degrees. So what we've seen is with application of the way that we do this, we do a baseline movement assessment. Based off their movement assessment, we provide them an exercise program that is leveled based on what their movements are. So, if your movement is X, you go to level 1. If it's Y, you go to level 2. And then we have them do that in a fatigue state. So what we do is we have them do their practice. And then at the conclusion of practice, then they do the exercises, because they take the stimulus of practice to create fatigue. And then they're going into this exercise program in a fatigue state. And that does two things. One is, from a specificity standpoint, is you're training for fatigue, so that when you are tired, you're actually moving better, you're less likely to get injured, and you're performing better. And then two is, from a volume perspective, I don't have to do the same volume that I would normally have to do if you're rested. because you're already a little bit tired. I can actually get the same training effect with less exercise, if that makes sense.
Yeah. So basically you're training the athlete in the most sport specific task as possible, even mimicking the environment as making them fatigued. And I'm assuming
Yes.
and do you feel like that's an important aspect of ACL rehab that's often missed?
So, oh my gosh, that's a hot debate right now. Matter of fact, Timothy Hewitt just tweeted something the other day that fatigue does not matter. Because what happens is the literature shows that fatigue, we've not vetted out that fatigue truly is a risk factor for ACLs. As intuitive it is to everybody, the researchers have not figured out. I feel like the researchers have not figured out why that is the case. Matter of fact, there's a researcher out there. Her name is Dawn Comstock, and she developed the database that all athletic training EMRs go into, where most of this research is pulled from. And I asked her about this scenario. So I had a soccer player who was in a soccer tournament. She played all day on Friday. They concluded at the end of the day. They wrapped up, got off the field at 9 o'clock, went to their hotel, and teenagers, they went right to sleep and didn't stay up or anything like that. They got up the next morning. They were on the field at 6 o'clock in the morning. They started their first game at 7, and she tore her ACL in the first quarter of the game. In that instance, her ACL injury is documented as a non-fatigued incident, but we would all agree that fatigue that she had the day before and the lack of sleep that she had coming off early in the morning, she is tired. She is fatigued. But the way that the research looks at it, they only look at the first quarter. They don't take all of those other factors into play. So, if you look at the literature, there's a lot of literature that shows that fatigue changes running biomechanics. Fatigue changes loading of the lumbar spine. Fatigue changes loading of the rotator cuff in pitchers. For some reason, the ACL is immune to fatigue. I don't believe that. Yeah. I think we just haven't figured out how to research it. So fatigue is important to me. And what I found is that when we do address it in the way that we do, we have a significant reduction of not just ACL injuries, but all lower extremity injuries. And most importantly, we actually track claim submission data. So we also see a significant decrease in healthcare costs, because the other thing that we see is that when injuries do occur, the severity of those injuries is less. So when you are running down the field and your knee goes into that valgus, maybe you get a meniscal injury versus a meniscal tear. So which is some time off the field and some ice versus actually having surgery. So what we found is that the severity of the injuries was actually much less. So our surgical cases dropped significantly. So we had a decrease in overall injuries. We had a decrease in healthcare costs, and surgery cases were significantly reduced.
Yeah, that's really interesting. Just the idea of just like measuring long-term fatigue, because I know even for me, when I'm doing training at all, there's days where I'm like, man, I just don't have it today, and like maybe that the training wasn't as good, or I didn't get enough sleep the night before. And in the research, it's got to be significantly difficult to try and measure that, especially in an athletic population who's constantly on the go. There's constantly traveling. Their kids, and their diet's probably not always good. And why do you think, though? You had mentioned earlier that women's soccer is more prone to injuries. Is that across the board in regards to women's sports that they're seeing more injuries, and maybe why is that?
Yeah, there are structural things that are different between men and women. The pelvis of a woman is wider, so that increases the Q angle at the knee, and that Q angle can put more stress on the ACL. The femoral notch that the ACL fits into is narrower in a female. So when they move into 10 degrees of valgus, maybe there's more rubbing on the ACL from that femoral notch. The size of the ACL is smaller. And, since Title IX, women are getting more involved in sports. But the resistance training that goes along with that, typically you don't see that as much in female athletes. So there's not as much strength training going on in female athletes. So I think there's a lot of factors that feed into that. And, so you put all of those things together, and you put them in a sport where they're doing a lot of cutting and whatnot, it puts them at higher risk. 3 to 8 times greater risk for an ACL injury, according to the research. And that's pretty wide range, but it's 3 to 8 times, depending on what sport you're looking at, what age you're looking at, et cetera. You throw concussion on top of that and it gets even higher. So I think that, even though female athletes are at greater risk, I think there are things that you can do that significantly reduce that risk. And number one is really focus on recovery. I do a ton of stuff with NormaTec, HyperIce. There's great research out there that shows, a 30-minute cycle in a NormaTec compression system is the equivalent of a 12-hour rest cycle. You get that kind of physiological recovery. There's also making sure that nutrition is spot on. Your body recovers through chemical reactions. And if you're putting junk into the system, you're going to get junk out of the system. Sure. So making sure that, you're optimizing your nutrition, making sure that you're optimizing your hydration. Again, 1% dehydration results in a 10% decrease in performance. Hydration is absolutely critical for the healing process. So making sure that hydration is high, making sure that kids aren't doing year-round sports. There's some great studies published looking at multi-sport athletes versus single sport athletes. Single sport athletes are at much greater risk for ACL injuries versus multi-sport athletes. It's clear. The studies are very clear on that. You cannot go soccer 12 months out of the year. It's just, it sets people up for greater problems. And most people think if I do that, they're going to play better at soccer. And what the studies show is that you actually get better performance doing multi-sport, having multi-sports to the athlete.
Now, who do you think, especially at the high school level, in collegiate sports and the professional level, we have clinicians, at least physical therapists and athletic trainers, and sometimes high school, they have, people who are trying to at least talk in the ear of strength and conditioning coaches, or at least coaches to be like, hey, like maybe we're overtraining them. And then in high school, do you think that it should be the coach's responsibility to try and manage some of this fatigue? Or do you think that physical therapists should be more active within the high school community? I guess I'm wondering if there's just a discrepancy in that. Because I know for me, I grew up in a very small town. I didn't have a physical therapist. I didn't have an athletic trainer or anything like that. And I can imagine there's tons of schools, tons of high schools all over the country where they have athletes where they haven't even talked to a physical therapist or heard anything that we're talking about today. And so do you think that's also a lag, or at least a missing thing that we need to get incorporated with?
Yeah, a couple of things. One, I think first and foremost, parents. As a parent, I've got a 17-year-old wrestler, and wrestling is a very, very tough sport. And he's at a high school that have been state champions for the last 10 years. And so, their wrestling season goes through wrestling season, and then they keep training. And so, I've actually had conversations with their coach, because I'm seeing a lot of their kids getting broken down. And what I ended up doing as a physical therapist and as a parent is actually tied them up to NormaTec, and now got the school to get 3 systems of NormaTec. Nice. So that kids are getting some form of recovery. Now the likelihood of me actually changing the mind of a wrestling coach, good luck. But at least what I can do is I can supplement some things in there. The other thing is, as a parent, I'm making sure that my son's diet is good and solid, making sure his hydration is good and solid. He's probably one of the only kids that carries around a gallon jug to school. And what we also do is we pull him out when he's too tired. If I see that he's not sleeping well, I'm seeing that his grades are slipping, I'm seeing that he's dragging around the house, I'll pull him out of practice. I don't care. Let coach pull him out of a match. At the end of the day, I'm not in this for high school. I'm in this for the long run. I'm into it for his life. Right. I don't want him to get messed up in high school, because he's not going to be a pro wrestler. A lot of the parents think, well, this is going to be the potential for scholarship, et cetera. Do you know if you tear your ACL prior to Division I career, you are 3 times more likely to re-injure in a Division I career, and you are 50% more likely to cost the university more money because of your previous ACL injury. Schools know that. That study is RUG, American Journal of Sports Medicine, 2014. It's been out there for a while. Schools know that fact, and they are making decisions for recruitment based off of that fact. You got an athlete who's high level, previous ACL injury, and an athlete who's a little bit lower level, no ACL injury. They're going to take this athlete all day long, because what the studies show is that this athlete is going to spend 50% more time on the DL than this athlete.
Wow. Even at that level, that's insane.
Even at that level, that's Division I.
That's insane.
Yeah.
Well, I mean, it makes sense. I mean, from their perspective, I mean, the university is about money as well. So I can see how they would want to be able to try to maximize that. Well, we've been kind of going around the idea of your objective, basically your objective data capturing device. And you've developed this thing called AMI through ViPerforamnce. And maybe let's discuss like, how does it work? And then when in the rehab process do you start measuring patients?
Sure. Yeah, so it's called the ViPerforamnce AMI, or the Athletic Movement Index. It is where we partnered with Dorsavi, an Australian-based company, to utilize their wearable sensor. The sensor has an IMU in it, inertial measurement unit, has an accelerometer, gyrometer, magnetometer. So it detects motion, rotation, and acceleration data all at the same time. So what allows us to do is stick the sensor onto the individual, go through a series of movements, and we can record their biomechanics within 3% of a Viacon system. Viacon system is the biomechanics lab where they put all the little dots all over you. So we're within 3% of that. The assessment takes about 15 minutes. Now in sports, we use this in mass physicals. People are like, well, 15, 20 minutes, man, that seems like a lot of time to do mass physicals. We've done Division I colleges, 450 athletes, gone through all of the athletes. Last summer, I was in Memphis, Tennessee. We did Memphis Fire. We did 1,800 firefighters. So it is possible. You can do it. It can be efficiently, and you can get some very good data. That being said, how we use it in the most part, there's several different ways people use it. Number one is for baseline data, getting baseline data for pre-physicals, so that you can create training programs to help to improve their biomechanics. Because two things that we know: one, if we improve their biomechanics, force output goes up, sprint speed goes up, vertical jump goes up. Number two is that we know that if we improve their biomechanics, injury risk goes down. So that's one way we use it. The other way we use it is clinical. So after somebody's been injured, you can phase the assessment, so that you can phase it based on where they are in their protocol. So maybe they're only doing bilateral stuff, so you can go up to the squat test and get some good information, see where they're at, adjust and correct those things that you're seeing, so that when they're ready to go to single limb training, you can actually assess single limb training. The beauty of the system is that it can be used throughout the rehab process. And then when they're ready to return to sport, we actually have what we call an ACL decel test that we throw on top of it. So we do a full movement assessment. Then we put the sensors on you, and we have you go out on the field, and we do a 30-yard max acceleration, deceleration. And what it allows me to do is see what your limb symmetry index is, how you're loading your right side versus your left side, both at heel strike as well as during the deceleration phases. So it allows me to get some very objective data, what we call limb symmetry index, which is the comparison of right side to left side, that we look at. But if you move horrible on your left side and horrible on your right side, and you're 100% limb symmetry, that doesn't really make a lot of sense. So the other factor that we use is what we call limb quality index. So we look for a quality of that movement. Are you staying within the recommended zone for degrees of valgus, and most importantly, speed at which that valgus occurs? Because we have some normative data based on over 4,000 norms for athletes, looking at the speed of valgus with single leg squat, single leg hop, and single leg hop plant. So we know what those numbers are, and are you staying within those quality indexes?
So when you get a measurement, you're comparing it to other athletes. You're not comparing it to the other limb.
So we compare it to the other limb and we compare it to normative data because there's a good study out there by Ren, again, American Journal of Sports Medicine, 2018. And what basically they showed is that you can have 100% limb symmetry index and your biomechanics can be crap. If you've seen the athlete that jumps down and both knees go in towards midline, that athlete is 100% symmetrical, but we would all agree they're still at risk for injury, right? Because they're both knees are going in towards valgus. They're both going in at a high rate of speed. So we look at limb symmetry index. How do you compare to your opposite side? At the same time, what we also look at is that quality index. The other thing about limb symmetry index that we have to remember is there's a significant deconditioning aspect that happens on the uninvolved side. Because you're not on the field, you're not running, you're not doing the normal things you're doing, you're not doing your normal weightlifting, you're not doing that normal conditioning, that left side is deconditioned. So basically what you're comparing it to is your operative side to a deconditioned side. So we have to remember that. That's why we look at the limb quality index as well, and really looking at those quality factors.
Yeah, because a lot of the ACL research they want your leg to be 90 or 98% of the other limb. And it's like, well, if that other limb got fatigued during the rehab process, it's like, well, what are we really measuring towards?
Right. So there's a concept called absolute LSI. And absolute LSI comes in when you do a baseline assessment. So in an ideal world, if you're at a team, you've done a baseline AMI, and then throughout the season, the person got injured. And then you take let's say they injured their right side. Then you can compare their right side to their left side of the pre-injury, pre-season assessment, because that's in a conditioned state, if that makes sense.
Yeah.
So that absolute LSI, that's a term that's used in the literature. Absolute LSI is basically comparing it to a baseline assessment.
And now, how did you think about the exercises that you want to include and to measure? Because it's one thing to say like, okay, we need to compare the left and right side. We need to compare acceleration, deceleration, but there's a trillion ways for you to do that. So
right.
How did you tease out which exercises, which movements, which drills that you wanted to incorporate in the testing?
So number one, there's I think I cite over 1,400 different papers from in our presentation related to how we got to where we are. What I basically did is I went to the literature and I said, okay, what do they look at? What do the biomechanists look at? When Hewitt is looking at dynamic valgus in soccer players, football players, lacrosse players, whatever type of player he's looking at, he is not doing a specific movement for that specific sport. He does one test. So what we did is we went to all the literature and said, okay, what are they doing and how are they looking at it? So that's how we came up with a single leg squat, a single leg hop. We do a multi-directional hop. So we do forwards, backwards, lateral, and medial. And we do it in that sequence: single leg squat, single leg hop, and then the multi-directional hop. And again, pulled that directly from the research. Now there are 100 different ways that you can do that. What we had to do is we had to do it in the most efficient manner that we could. And so, when I first started doing this, I think we had a total of maybe 11 tests. It was too long. There's no team that's going to do that for that long. The other thing is the number of reps that we do. We do a significant number of reps. The entire test consists of 3 1-minute time tests and then 83 reps total. So there is some level of fatigue that's brought into it. However, if you're looking at your Division I soccer players or you're looking at your UFC guys, that's not going to fatigue them. So we actually have a fatigue protocol that we'll do before with those types of athletes, and that's called the FAST-FP. It's a Functional Agility Short-Term Fatigue Protocol. It was published in the Journal of Athletic Training 2012. It's the only fatigue protocol that's been shown to change biomechanics, and that's why we use it. Super simple to do. It takes 4 minutes to do it, and it has an impact on multi-directional biomechanics. So all that said, the other things that we put in there are the planks and the side planks. So originally I started doing that because early on in the early phases, I moved to Tennessee. Being naive, I didn't know women's basketball. I went up to meet this coach named Pat Summit, who I had no idea who she was very well informed who she was afterwards. And one of the things she was telling me is that with her basketball players, she found that athletes who could not pass a side plank and a plank, got injured more and performed poorly during their seasons. And so one of the things that they did as a part of their assessing players is they did planks and side planks. So I'm like, that's freaking brilliant. Here's a top level, nationally recognized coach who's figured this out. Maybe we need to start looking at that. So we started to include the plank and the side plank early on in the process. Fast forward, DeBlazier, American Journal of Sports Medicine, 2020, and then Jong, American Journal of Sports Medicine, 2021, showed that if your performance on the plank and the side plank is poor, you're 3 times more likely to tear your ACL. So again, we have the evidence now to show it, but originally I started using it because this high-level coach was seeing those correlations, and it, quite honestly, the whole thing with fatigue, reason that I started doing that is we were at Stanford University doing a research study. We're taking all these soccer players through, and they're looking really good on the assessment. And I'm like, dang, man, these athletes look really awesome. And then this is Division I school. And then these 2 other athletes came in at the end, and they were supposed to be their best athletes, and they looked horrible. And I'm like, so I pulled the coach aside, and I'm like, I don't understand this. Like, your best players look the worst. And he's like, well, because I just put him through a fatigue protocol. He's like, what I know is that I put them through a fatigue protocol, and then I have them run drills, and how they move during those drills will tell me if they're the quality of athlete that I need. And I'm like, holy crap, like, here's a coach who's, again, figured this out. So that's when we started looking for fatigue protocols. And that's how I came to the Fast FP and started using the Fast FP with our Division I, especially our Division I soccer players, just because they were so conditioned. And I wasn't seeing the biomechanical flaws until I fatigued them out. And then it became very clear where we need to work on.
That's amazing that they were able to figure it out with any objective data. I mean,
right.
And it's tough too, because like from our perspective, physical therapy always says that like anecdotal or like, the case study evidence isn't always like the strongest. So you're like, oh, well, I don't know. But then you have these 2 people where it's like, well, comes out later. And it's like, well, shit, actually, they were actually right.
Yeah, right.
So,
right.
Yeah. Not to say that you should go.
That's why he's a world-class coach.
Right. Yeah. And then again, these people were at top level universities, Division I, and they deal with athletes all the time. It's not to say to go out and believe every Joe Schmo, but it's, I think case studies should be used as a way to maybe spark curiosity in your own brain and be like, why is that working for them? It's not to say like you need to throw everything out and be like, oh, I need to be doing this now. It's just like, why is that working for them? And maybe there's something that they're doing right that maybe you can become curious about.
Well, and I'll give you a case in point. I guarantee you that any therapist could go and sit with Nick Saban for an entire 3 days and figure out things that they never knew about athletes that he's figured out.
Right.
And he's figured it out because he knows what makes an elite athlete. Now, Alabama has a sports scientist that is actually collecting all that data and proving all that out. So, fortunately, I figured out early on, like, an elite level coach like that, they've got a database. They just don't have it written out and they don't have it published, but they've figured it out. That's why they're getting millions of dollars to be a coach, because they figured it out. They know what it looks like. They know what those athletes look like. And taking that knowledge is to me, it was solid, solid knowledge, and it's proven itself out in the research.
Has that been the most fun part for you, just developing this and talking to high-level coaches and figuring out some of these interesting variables that perhaps we as clinicians maybe wouldn't even looked at?
The very best part of all of this is that I have gotten to communicate with some of the best therapists in the country, and we all just resonate with one another. That has by far been the most the thing I love the most. And I've got a group of people that I communicate with on a semi-regular basis. And I love it. I absolutely love it, because hearing high-level therapists like that who, one, love the work that we're doing, they see value in it, it's a game changer for them. That totally makes my day. I know I'm on the right track when I get people like that on board, and see what they're doing, they're already doing. That inspires me. It inspires me. More so than coaches, because that is boots on the ground, and those are people that are making a difference in people.
Right.
Not that coaches don't.
Right. And especially within healthcare, because healthcare can be so draining for a lot of individuals, and
Yeah,
a lot of individuals get into healthcare for the wrong reasons. And unfortunately, it leads to a lot of fatigue and burnout. And, I see it a lot, especially in the realm of healthcare, because we do get burdened with a lot of other variables that perhaps
sure.
aren't built within this podcast right now. But definitely can definitely, if you're a clinician out there who you're like not seeing the things and you're only seeing clinicians who are just doing the day to day and they're not really looking for this evidence, it can definitely be kind of draining on your self-confidence, and also your willingness to progress the profession
Yeah.
alone.
It's funny because I just had this conversation, and God, I totally avoid doing this, but I got into some debate on a Facebook forum with another PT, and he was a younger PT. And I think probably the reason I got involved with it is because he called me a boomer. But but the thing I was trying to explain to him is like, you know what, you are solely responsible for your direction. Like, no one is going to dictate what you do with this profession. You have to dictate it. You have to go and pull the journal articles. You have to do the stuff on the side. You have to choose what you're going to do and what you're not going to do. You have a job. Everybody has a job. But if you really want to make this a profession, you got to invest more into it than 9 to 5. 9 to 5, you don't become an elite level clinician 9 to 5. You become an elite level clinician outside of 9 to 5. And I think that's what I was trying to explain, but I probably didn't come across well
No,
enough.
you did. No, you did for sure. And I think that's something that people also need to hear, especially if you're a student, where like, hey, if you're going to get into outpatient or at least orthopedics, and understand that there's, and not even just orthopedics. I mean, if you're doing neuro or you're doing cardio, there's going to be, most of your learning is going to happen outside of the classroom. And unfortunately, that may take you learning outside of your patient caseload. And that may be taking time out of your weekend, your week to educate yourself and continue learning and growing and become a better clinician. Because unfortunately, this profession is a moving target and it's still new and there's a lot of work to be done.
Well, and I tell you, I'm looking around my desk. I've got at least 7 books on my desk and 15 journals. That tells you, I mean, that's because I'm constantly looking stuff up. Even I've been in practice 25 years and I still look stuff up. And that's what this is about, and because the way that we looked at things 10 years ago is going to be different than the way you look at it today.
Yeah, for sure. And, getting back to, I wanted to touch on this highlight importance because you talked about fatigue, but another important, you mentioned that you also use a Tampa scale, and that's also for
kinesiophobia.
Yeah, kinesiophobia, which is just the fear-based movement. And, how would you say that, how important is a patient's confidence in regards to getting back into sport? And do you incorporate it within this ViPerforamnce assessment so that way patients feel that they're getting back and they feel that they're ready for the sport? Because again, if you don't feel like you're ready and you feel like you can't put pressure through that knee, it might not be a good time to get them started back, put them back into sport. So I guess, how have you been able to build patient confidence and get them back on the field feeling that way?
Absolutely. So, a couple of things. Number one is there's basically 2 forms out there that really look at kinesiophobia. That's pretty, forgive me, my allergies.
Good.
That's really looking at kinesiophobia. One is called the ACL RSI. And that is been out by Ian Weber, who's out of Melbourne, Australia. When you look at the research related to the ACL RSI, it does measure some level of fear, but what it has not been associated with very strongly is re-injury rate or any change in performance or any change in movement. The TSK11, Paterno really has done a lot of really good work on this. I think the first study I would cite is probably 2015, where Paterno looked at the TSK11 and he found that scores of 19 or greater, you're 13 times more likely to have a re-injury. You're 8 times more likely to have an altered LSI. You're 7 times more likely to have a quad difference on the surgical side versus non-surgical side. So there's a strong core. And then further, there are other studies that show that when you have high levels of kinesiophobia, when you do a vertical drop jump test, you unload the surgical side. And so that's very similar to what we're seeing, is that we're seeing that when TSK numbers are high, movement changes. One of the things that we measure is if you do a squat and I put a plumb line down from your cervical spine to your sacrum and you shift your weight to one side or to the other, we call it a lateral shift. The research calls it a lateral displacement of the pelvis during the squatting motion. Much more articulate than I call it lateral shift. And what we see is that when people have high levels of kinesiophobia, they shift their weight away from that operative side during a squatting motion. That has to be corrected, because what we find is whether it's the confidence that's created with it, but as soon as you start to correct the movements, kinesiophobia goes down. Okay. So there's high levels of kinesiophobia that's associated with quad weakness. There was a study published by Ho in 2014 that showed that quad deficit, your biomechanics in the frontal plane are going to be you're going to have a lot worse frontal plane motion. So really pushing that quad strength, that's why it goes back to BFR. One of the things that we're starting to look at now is early implementation of BFR, the impact on the AMI and the impact on the TSK11. We have a new version of the AMI coming out that will incorporate the TSK11. So the TSK11 will be electronically captured along with the movement, because then we can, my goal is to correlate what of the 11 questions, what questions are highest correlated to single leg squat, which ones are highest correlated to squat, which ones are highest correlated to, because then it gives us clinically like things that we need to work on, right? Like I could do this patient reported outcome and go, okay, we need to work on your squat. I mean, that to me is fascinating, right? But so the other thing that we're looking at is early implementation of BFR and the impact that has on TSK11. Knowing that Ho has already showed that if you've got weak quads, you're going to have high levels of kinesiophobia. What happens if we implement that BFR sooner? Do those levels of kinesiophobia drop faster?
I was gonna say, just building off of that, do you believe that the therapist has a role in building patient confidence?
Absolutely.
The return to sport. Do you how much do you feel like it plays a role?
So there's have you heard the term sport locus of control? So sport locus of control is that I am in control of my destiny. And one of the things that happens, and there's studies that show this, is that one thing that happens after an ACL injury is that an athlete who's been in control of all of their destiny all of a sudden has relinquished that control to a physician. The physician's going to tell them when they can start walking. They're going to tell them when they can take a brace off. They're going to tell them when they can start getting off their crutches. The physical therapist is going to tell them when they can start hopping. They're going to tell them when they can start running. They're going to tell them when they can return to sport. So one of the things that, we talk about in my course is how you relinquish that sport locus of control on visit one. The sooner you do that, the sooner you give that athlete that control, the better. The thing is that you have to remember that athlete is going through a lot of psychological issues at that point. For a lot of athletes, especially like a Division I athlete, athletics has been a big part of their life. Now imagine that athlete, they've torn their ACL, they're sitting there at Thanksgiving dinner. No one wants to ask them about their sport. Normally during Thanksgiving dinner, everybody's asking, how's soccer going? How's your season going? How are things going? Now nobody wants to say it because she's injured or he's injured, right? So that we got to remember the psychological impact. I've lost my identity. That's how I identify myself. I am an athlete first and foremost. I'm a student second, right? So we lose part of that identity. So I think that as therapists, we need to recognize that, and we need to really provide our patients with that sport locus of control visit one. The other thing that I used to do a lot is I would schedule all my ACLs around the same time. So I would have somebody who's day 2 post-op sitting next to somebody who's 3 months post-op, because I can tell them all things I want to tell them. But when that person next to him says, oh, hey, by the way, do this or do that. Oh man, I was there too. And I did this or I did that. There's so much conversation that goes on and so much, building up of the athlete that can go on, and having someone there to help them walk through who's beyond just the clinician. So I think that there's so many key pieces to that ACL rehab that we can do that we don't typically think about. that we need to be more cognizant of. But I would say the very first and foremost thing is on that visit one is really give them that sport locus of control. I always tell my athletes, like, we have a protocol we're going to follow. We have things that we're going to do. At the end of the day, you're in control. At the end of the day, I'm going to tell you what to do, but if you don't do it, that's on you. At the end of the day, I'm going to give you all the exercise you need to do. That's on you. Because if you want to hit these timelines, that's all up to you. You're in full control of this. You're choosing your destiny. You want to be back at 110%. I will get you back at 110%, but you got to do what I tell you to do. So you give them that control. It sounds simple, but so many times it's not done. Certainly. And the athlete feels like they've lost the control.
I believe it. And do you believe the future of this, and obviously the future is going to be measuring with objective measuring tools such as, ViPerforamnce and so on. But do you believe that building a community of other, of individuals and patients who have gone through similar injuries is kind of the future of where ACL needs to go?
Yeah, I do. I think, I think having that community, I think, and quite honestly, Instagram has got some positive pieces to it. There's a lot of ACL groups out there. There's Facebook groups. And I think it's a great avenue to, post your questions and ask like, hey, I'm having this problem with my ACL, sometimes you can't reach you're a therapist, you can't reach your doctor, you need somebody to talk to. And I think, platforms like that, is as many negative sides as there are to social media, there's also the positive sides. And there's a lot of really good ACL groups out there to help people walk through that.
And again, just building relationships, connecting with other therapists, connecting with other patients who've gone through the same thing. It's all about building community and just talking to one another. And I think we've done an amazing job covering basically the world of ACL and, what you've been doing to push the profession in a better direction and make it objective and make patients feel better. I want to thank you for coming on the podcast. And we're going to close out with the last 3 questions that I ask all my interviewees. And first question is if you had the attention of everyone in the world for 30 seconds, what would you say?
Be positive, be more positive, both internally and externally. Is that if you talk negative of yourself, you're going to get negative. If you talk negative of others, you're going to get negative. Talk more positive, be more positive. I think the world would do a lot better if we were all just had a better attitude in the way that we go about things.
Who would have thought? Just thinking positive. Everyone's got to get there. At least that's where we got to start.
Amen.
Second question. What book do you recommend, whether a book you're reading now or in the past?
Okay. So this is going to sound really corny. Palestanga. It's Anatomy and Human Function. It's one of my favorite books. It really taught me as a therapist, not just origin, insertion, innervation, but also how muscle functions in both open kinetic chain and closed kinetic chain. So it was an instrumental book for me really understanding how human movement occurs in a closed kinetic chain. I know it's kind of corny, but
no, I'll have to look into it myself. Last question: where can people learn more about you? What we talked about today?
So they can follow me on Instagram at BJJPT_ACL guy. I also have a website, combatathletescienceinstitute.com. And obviously they can always follow me on LinkedIn as well.
Yeah, if you guys aren't following him already, you really should. He's got a lot of great information. He's doing certainly a lot for the physical therapy profession, and I'm excited for what you're going to do next. And Trent, thank you so much for coming on the podcast again. I really appreciate it.
Thank you, Mike. Thanks for having me. I appreciate it.